Superficial mycoses are those fungal infections that really only colonize the outer layer of the skin or hair or nails. And remember when we talked about them in a previous section, we talked about the idea that they really don't elicit an immune response. A patient is not going to experience itching or pain or anything like that when they have a superficial fungal infection. Generally, what we're talking about is these are going to have a cosmetic concern. And by that, I mean they cause changes to the pigmentation. They have a very simple diagnosis and they're relatively easy to treat. So some of our superficial mycoses are caused by a number of different species. So you can have, for example, members of a complex that cause, I'm really terrible at pronouncing all of these species names, but pityriasis versicolor is not a species name. It's actually what it's called when a patient has this fungal infection. And maybe what you could gather here is we're going to have a change in the color. This is a complex of fungi, so a number of closely related fungi that cause the skin discoloration. And the reason that we have some taxonomic, maybe, I don't want to say confusion, but maybe a little bit of muddying of the taxonomic waters is because a lot of these fungi have only relatively recently had molecular characterization done, like genome sequencing, in order to really tease apart the taxonomy. What you would see in a patient sample is some yeast-shaped cells and some hyphae. And generally, again, because this is superficial, you're mostly doing a skin scraping. And so for the most part, with this particular superficial mycosis, you are looking at person-to-person spread, and these are not going to be environmental. So this is basically a fungus that has adapted itself to work in humans, right, to cause human disease. A lot of our fungal infections are going to have the same characteristic where they're found most frequently in warm tropical climates, just because fungi do better in those types of environments. But many fungi can be found worldwide. And so what you'll see in a patient who has this superficial infection is that they have lesions that are small and differentially pigmented. So in this instance, we have a person who is Caucasian or white, and they have developed more pigmented lesions. In a patient who has darker skin, any sort of on the scale of darker skin, if a patient has darker skin, more pigmented skin, often what you would see is the discolored patches would be lighter. It interferes with melanin. And so, of course, then the presentation would depend on the natural skin color. So in a patient who has less melanin, you'll see more melanated lesions. In a patient who has more melanated skin, you would see lesions that have less melanin. So that's what you'll see. Diagnosis by skin scraping. So you would just kind of scrape off these kind of extra layers of skin there, look at them under a microscope, and you can see the yeast and the hyphae. Culture takes about 5 to 7 days. And in most patients, this is actually chronic. It'll just spread around the body. So it's difficult to get rid of. But the treatments are really going to be topical, right? For most patients, an oral antifungal is going to be a little bit stronger than they need. And also it's harder to get the drug to these extra surfaces of the skin. If you have a patient who does have this like all over their body, you can try oral antifungals, but especially if it's localized, like say it was just localized to this person's chest, you could just do a topical, or if it was on their head, you could do a shampoo to help kind of clear it from these external layers of the skin. The other superficial mycosis is the manifestation is tinea nigra, where again you have these differentially pigmented areas of the skin. You will see the yeast cells kind of in the process of budding and some hyphal cells if you do a skin scraping and look at that under the microscope. Generally, this is found in tropical or subtropical areas. And when we say traumatic inoculation into superficial layers, like a cut, basically, it got in through not just touching, but through like a cut or, I don't know, like a needle or something, right? It just got in there somehow, splinter. Now, the reason that this one comes up a little bit is because the lesion actually looks like malignant melanoma. So a patient might come in and say, I think I have skin cancer, because it's kind of this pigmented, rapid growing, irregular border, right? All those characteristics, but then luckily it's just a fungal infection and not skin cancer. So again, you can diagnose through microscopy of skin scrapings or culture for about 3 weeks. And topical therapy is what's going to be helpful here. When we talk about cutaneous mycoses, they usually call it dermatophytosis. A long time ago, people thought that fungi were plants, so that's why it has the phytosis. They're not plants, right? They're fungi. There are 3 genera of fungi that are most commonly implicated in causing these cutaneous mycoses. Now, with the cutaneous mycoses, they will get deeper into the skin or hair or nails than some of the superficial mycoses. They can break down keratin, but they rarely will penetrate below the granular layer of the epidermis. And so here's your skin anatomy. So the granular layer, right, the stratum granulosum, usually what you're looking at is that the fungal infection will be kind of limited to these upper layers. Not, the corneum and the lucidum, not down into the granulosum. When people have these fungal infections, they're called tinnias or ringworms. So if you've ever heard of ringworm, contrary to its name, ringworm is not a worm, it's a fungal infection. Depending on where on the body the infection is, the name is a little bit different. So tinea capitis is scalp, eyebrows, eyelashes. Tinea barbae, if you have a beard. Tinea corporis, the smooth skin of the body, anywhere basically except for these other specified places. Tinea cruris is of the groin, aka jock itch. Tinea pedis of the foot, aka athlete's foot, and tinea unguinum of the nails, or onychomycosis. With these fungal infections, they can be geophilic, meaning you got it from exposure to the fungus living in the environment. They can be zoophilic, meaning you got it from an animal. Or they can be anthropophilic, meaning you got it from another person. If it's a person-to-person spread, in that case, you often see chronic infections, but less inflammatory, because those strains or species of the fungus that are moving from person to person to person have evolved or adapted a little bit better to being with the person. And one of the issues is, I don't know about you, but if a part of my body is itchy, or it was flaky or red or something, I'm probably going to seek treatment. But if the fungus can kind of, hide a little bit, below the radar, you're less likely to get it treated. The infections from, the environment or from animals tend to be a little bit more inflammatory, but that's not to say that an anthropophilic fungal infection also can't be inflammatory. So, athlete's foot is usually spread person to person, and it can cause, swelling and peeling and itching and redness of the feet. So we've got some of the images here of some of these cutaneous mycoses. So here's capitis on the scalp, barbae, right, the mustache and beard, corporis, here's your jock itch. This is a massive case of jock itch, by the way. Like, you would hope that you never see something like that. An athlete's foot, and then here's one of the fungal infections of the nails. So these are just some of the presentations of the disease. One of the other things that I don't know if I've mentioned throughout the semester, but I do want you to think about is especially those of you who are going to be working on the patient side. You're going to be like seeing patients, a doctor, PA, whatever. A lot of the pictures that I show you they're from the textbook, or they're, from Wikipedia or whatever. They're like the easiest pictures to find. And they're all, for the most part, on patients who are white. A lot of your patients are not going to be white. And the manifestations of disease, while yes, it's going to be a rash, it's going to be redness, it's going to be whatever, it may not look the same on a patient who's not white. So one of the things that I'll really encourage you to do as you enter PA school or medical school or whatever in your future career is to really ask, the clinicians that you're working with, what does this look like in people who have different color skin? What is a Lyme disease, right? The erythema migrans, what does that look like? What does measles look like? What does jock itch look like in somebody who has different pigment in their skin? So maybe that's my future work, is to try to find better pictures. But unfortunately, a lot of the pictures that are published for these types of classes are in Caucasian people. For these cutaneous fungal infections, they can be diagnosed by microscopy. You'll typically see hyphae, but a lot of the time, let's be real. If let's say you're a pediatrician or a general, physician, and a 13-year-old boy comes in with his stinky, gross feet, you're like, yeah, that's probably athlete's foot. Or a 13-year-old girl. I'm not saying it had to be boys or girls, right? Teenager, like a teenager comes in with their nasty, stinky feet, and you're like, yeah, that's probably athlete's foot, because maybe they are an athlete and they share a shower, or they put on their sweaty socks or whatever. A lot of times they can be diagnosed just by looking at what the infection looks like in that part of the body. But if you need to, you can always do microscopy. The 3 genera that cause these types of infections are relatively easy to culture, but they do take a little while to grow. And for a lot of these infections, especially for those that are in the skin, topical treatments are really effective. And a lot of times you can just buy them at the pharmacy or, Walgreens or CVS. You don't actually need a prescription. So especially for athlete's foot, I'm thinking of like the commercial tough actin tenactin, right? You can just buy that at the store. You don't have to go to the doctor. If it's not responding to therapy, if you're not sure what you've got, of course, please do seek medical treatment, and you can get a prescription strength antifungal as well. For patients who have involvement like on the scalp, it's harder to get treatment. You may have to get a special shampoo. If you have it in the nail, that's also really challenging, because oftentimes it's not on the surface of the nail, it's like in the nail bed. So a topical therapy doesn't get in there. So for those patients, you may prescribe an oral antifungal to hopefully get it in there. But one of the challenges is that just nail fungal infections are very, very difficult to treat. And unfortunately, one of the best treatments is surgical removal of the nail, and then intensive oral therapy, and then lacquer therapy, basically like paint the nail when it grows back. To me, that sounds horrifying. I don't know what I would do if they told me like I had to have my nails removed. I would probably freak out. So I'm really glad that I've never had that happen, but that is an option for your patients that have chronic nail fungal infections. So here's a case study of one of these cutaneous mycoses or dermatophytosis in a patient who's immune compromised. So again, I'm talking mostly before this about patients who are otherwise healthy, but let's say we have a patient who's immune compromised. So it's a 55-year-old renal transplant recipient, so a kidney transplant with the nail infection and chronic athlete's foot, and has tender nodules, so pain on his left heel. He then developed papules and nodules on his right foot and calf. A skin biopsy demonstrated thick, round cells of a particular size. The skin biopsy grew trichophyton. This can be an invasive pathogen in immune-compromised hosts. The clinical presentation, histopathology, and early fungal culture actually suggested Blastomyces dermatitis. Blastomyces is a dangerous genus that's going to be one of our endemic or systemic fungi that we'll talk about. But the final identification was actually trichophyton. So basically this patient had athlete's foot, but because he was immune compromised, the athlete's foot started to move up his leg, and that was because of the renal transplant. So the kidney transplant patient will be on immune suppressive therapy for the rest of his life, and normally the immune system has no problem just kind of keeping athlete's foot to the toes, but because of that immune compromised status, it did spread. So while we kind of joke about athlete's foot and it's itchy and yucky and, oh, you get your tinactin, you'll be fine, as a clinician, you do have to consider the overall health of your patient and not just say, oh, athlete's foot, no big deal. And then this is a case of tinea capitis, or a scalp, basically like athlete's foot on the scalp, right? The fungal infection on the scalp. An 87-year-old woman who had a 2-year history of painful scaling scalp eruption and hair loss. Previous treatment included numerous courses of systemic antibiotics and prednisone, which is like an anti-inflammatory, without success. Of interest in her social history was that she had recently acquired several stray cats that she kept inside of her home. On physical examination, there were numerous pustules throughout the scalp with diffuse redness, crusting, and scale extending to the neck. There was extremely sparse scalp hair, so she basically lost all the hair on her scalp, and prominent posterior cervical swelling of the lymph nodes, so kind of the back of her neck. The lymph nodes were all swollen. She had no issues with her nails. An examination of the scalp was negative. A wood light examination, so like looking for things like lice. A skin biopsy grew a skin biopsy specimen and fungal bacterial viral cultures were obtained. Bacterial culture grew rare Enterococcus. Viral culture was negative. Scalp biopsy revealed a dermatophyte infection of trichophyton, same genus as the previous patient. The patient was treated with griolsifen, which is the drug that inhibits mitosis in fungi, and Selsun shampoo, which is kind of an antifungal shampoo. It's often given to people who have dandruff. When seen at a 2-week follow-up, the patient had new hair growth and resolution of her pustular eruption, with the brisk clinical response and culture growth of the trichophyton. Antifungal treatment continued for 8 weeks. The scalp hair grew back normally with no permanent hair loss. Adults with hair loss require an evaluation for tinea capitis, including fungal cultures. So this was most likely a fungal infection that she acquired from the cats.